LMFT is the manager of co-occurring disorders program at the University of California, San Diego Eating Disorders Center. She's a senior therapist as well, using her expertise in eating and substance abuse disorders, trauma, and grief, as well as specialized training in dialectical behavioral therapy, or DBT. Gina developed the comprehensive evidence-based COD track at UCSD Eating Disorder Center. Gina obtained her Master of Arts in Marital and Family Therapy at the University of San Diego, where she was the recipient of the Award of Distinction and the Dean's Merit Scholarship, and her Bachelor of Arts in Psychology from McGill University in Montreal, Canada. She also serves as adjunct faculty at the University of San Diego and a consultant for trauma-informed care. And Gina is going to be presenting today on demystifying the whack-a-mole, unique considerations for the treatment of co-occurring eating and substance abuse disorders. So Gina, I will turn it over to you.
Thank you so much, Kirsten, and thank you to ED Hope for having me here today. I'm really excited about it. It's morning time in California, so I'm just getting my day started. I'm sure many of you have enjoyed the previous presentation, and hopefully you'll have many questions for me today. I don't see the questions or the chat portion in my current view, but we'll definitely make sure that we have plenty of time to answer questions in the last 10 or 15 minutes of the presentation. So I welcome any questions that you have. I wanted to start by saying a little bit about myself and how I came to specialize in the co-occurrence of eating and substance use disorders. And it was definitely unplanned. My original sort of niche, my entry into the clinical field was really through addiction treatment. And I started by working in an acute psychiatric hospital setting right out of grad school. And I'm sure many of you can relate. It's sort of a whirlwind experience. You get probably some of the best knowledge that you can working in that type of setting. And one of the things that I found again and again in working in the substance abuse field was that many of my clients, in particular my female clients, had a background of trauma, in particular childhood trauma. And so I started to get interested in what it was exactly that, how there was a link between trauma and addiction. And for a certain percentage of those patients that I worked with, they also were endorsing eating disorder behaviors, but they were doing so in a way that wasn't very obvious to other people. And so they were purging or restricting their food or over-exercising, but they weren't getting the help that they needed for those behaviors. And I found myself in a position of not knowing how to help them, because here I was trying to treat their addiction and had absolutely no clue how to address what was also going on, which was, I later learned to be the concurrent eating disorder. And so that sort of sparked an interest for me in wondering, how are eating disorders and addiction and trauma all connected in some way? Is there a connection? What does that look like? And so a few years later, I ended up taking that sort of clinical interest and transitioning to the UCSD Eating Disorder Research and Treatment Program. And we're so lucky to have this incredible treatment here in San Diego, California. One of the only academic treatment programs that combines incredible research, cutting edge research on brain studies with eating disorder treatment. And I found that more of the patients here had addiction issues than we initially recognized. And so that sort of spurred this journey for me to dive into the eating disorder and substance abuse treatment and creating what I thought would be an absolutely necessary integrated model. So here I am today talking about the demystifying of the whack-a-mole, and I'll explain in a few slides why I chose the word whack-a-mole. Many of you are probably familiar with the concept of it, but I do often see many patients who struggle with this sort of whack-a-mole effect. When one behavior gets better, the other one tends to increase, and so on and so forth. And so we're going to talk about some of the considerations around working with this particular patient population. And I invite you to jump right in with me, and hopefully I will be able to address any of the pressing concerns and interests that you have. Before I move forward, I also want to add that I've noticed along my journey in the last 7 or so years that eating disorder treatments often exclude patients with addiction issues, and because they feel unprepared or unequipped to treat them, and also concurrently that there are substance abuse programs who will exclude taking on patients with an active eating disorder because they often feel like they can't attend to the complicated medical problems. And so this is ongoingly a frustration for many patients and their families, understandably so, because it feels like there are a lot of doors slammed in the face and no opportunities for obtaining true evidence-based treatment. And so that's one of the reasons why this was so important to me and ultimately to the clinic that I work in, is that we needed to find a place for these people to be able to get the treatment that they deserved. And I wanted to share that if you're not already familiar with the work of Timothy Brewerton, Amy Baker Dennis, and Tamara Pryor, you absolutely need to look into them. They are the pioneers in the world of concurrent eating and substance use disorders. And in fact, in 2014, they published a book called Eating Disorders, Addictions, and Substance Use Disorders. And it has a combination of all of the experts in the field coming together to address this very particular population. So I would highly, highly recommend looking them up. All right, so what are co-occurring disorders? You may have heard for many, many years people talking a lot about comorbidities and how one single mental health diagnosis may not always be the diagnosis that is given, that oftentimes our patients tend to have one or more diagnoses. But in recent years, there was a shift from comorbid to the term co-occurring, because we recognize that there could be more than one or two diagnoses in one given patient. And so the idea is that within co-occurring disorders, the individual experiences the co-occurrence of one substance use disorder and one or more mental health disorder. So you sort of see the overlap there between addiction and mental health. And it is, to my experience, that most individuals with addiction have an underlying mental health disorder, either diagnosed or undiagnosed. And so it's fair to say that co-occurring disorders is a much wider experience than we actually give it credit for. But I want to sort of present the caveat that a diagnosis of co-occurring disorders occurs when at least one disorder of each type can be established independent of the other and is not simply a cluster of symptoms. So for an example, people on stimulants such as cocaine, they tend to lose weight because cocaine suppresses appetite. But in and of itself, this does not diagnose someone with anorexia unless the restriction and appetite suppression occurs outside the cocaine use. So in and of itself, they have to be independent of one another to be diagnosed as co-occurring disorders. So some general statistics, we know that only a fraction of the people with co-occurring disorders actually receive treatment for their conditions, and yet we have upwards of 8 million people who, as we know it, struggle with co-occurring disorders. Up to 50% of individuals with eating disorders are also abusing substances, and this is from the National Center on Addiction and Substance Abuse. And what further we found was that the National Comorbidity Replication Study found that the lifetime co-occurrence of alcohol abuse in particular with eating disorders was between 25 and 34%, which is the highest substance abused for individuals with eating disorders. And in particular, bulimic behaviors, the binge purge subtypes of AN or BN, was the highest risk subgroup. So why are eating disorders and co-occurring disorders so prevalent? there are three components that I think are absolutely necessary in terms of understanding why these two in particular tend to co-occur. And as for many other co-occurring disorders, there are the combination of genetic predispositions, sort of that nature brain stuff. We know that eating disorders are genetic. We also know that substance abuse and addiction can run in families. So there is a strong genetic component to eating disorders and the co-occurrence of substance use disorders. And so we can't ignore that very important fact. But two other things make this sort of pull the trigger on whether someone experiences co-occurring disorders, and that is a combination of their environment, so the people, places, and things that they're around, as well as any early traumatic experiences. So as I mentioned at the top of this presentation, in my clinical experience very early on in my career, I could see immediately how childhood trauma in particular played such a strong role in the development of the addiction and ultimately an eating disorder. And part of this is because there are neural networks in the brain that shift when a trauma has occurred, and particularly in the early developmental stages of a child when their brain is still forming those neural networks. They can be interrupted by the trauma, particularly if it is a chronic trauma, something that's happened more than once, or if they haven't received any support or help around the trauma. So what we know is that there are interconnected pieces of a maladaptive puzzle that come together: this genetic predisposition, environment, and early traumatic experiences. And as they come together, the co-occurrence of these two disorders serve a function. So the example that I want to give is the example of Melissa, who is a case example that I wrote about in an article for ED Hope, I believe back in 2014, or something around then. And I gave this example of Melissa, who had experienced early childhood neglect. And what we saw throughout her lifetime was that she eventually built her identity around this core belief of not being enough and needing external validation from people in her life, which led to the development or learning that restriction and purging it equaled weight loss for her, which provided a sense of validation and pride. And in combination with that, she also learned that cocaine in particular and other stimulants suppressed her appetite, which helped her to restrict and ultimately lose the weight. So you could see that co-occurring disorders work in connection like a puzzle piece, clicking together, which for Melissa, it made sense because it reinforced that this core belief that she had needed to be fixed or changed somehow. And so these were the methods in which she had learned to feel better about herself. So the complicated function of co-occurring disorders is that they serve a myriad of benefits, so to speak, for the individual who experiences them. I like to say that before it became a problem, it was a solution, right? There was something about engaging in these behaviors that felt adaptive for the person, even though they weren't healthy behaviors and it was a maladaptive experience. It felt like it served a solution for them. And so when you meet clients who are engaging in behaviors that seem unreasonable or that seem disorganized or unhelpful in so many ways, and you're wondering, why do they keep doing these things when it's impacting their life in so many ways? Was that deep down there is a function that has served for them, and it helps them in many ways, even if over time that function changes and it is no longer adaptive for them. So some of the secondary functions that we see with co-occurring disorders is to avoid escape or numb feelings. And I think this is one of the most obvious ones, in particular with substance use disorders. People just don't want to feel the emotional pain that they feel. And so it is an incredibly quick and effective way to avoid, escape, and numb those feelings.
But the other part of it is that they also serve as a purpose to punish the negative self. And what I mean by this is that understanding it as a form of self-punishment. So the idea that I don't deserve to eat because I'm not a good person, or because people don't care about me, or because I'm worthless. And so this might be a way of managing excessive guilt that they experience, and often reaffirm the belief that they're worthless or unlovable. And in conjunction with that is decreasing shame or discomfort and managing their mood. What we found is that an incredibly high percentage of people with independent eating disorders or substance use disorders also deal with a mental health diagnosis like major depressive disorder or generalized anxiety disorder or PTSD. And so the substance and the eating disorder can serve to manage their mood, to help them feel a feeling of relief or a feeling of happiness again. In fact, I have worked with many patients over the years, and one more recently that said that she had been using cocaine very regularly because she had been feeling very depressed, and it gave her that high that she was looking for, that relief that she wanted, because she really was struggling with her mood. And those dopamine receptors were triggered when she used cocaine, and so she felt great on it. And finally, to reduce stress and anxiety, as you can imagine, with co-occurring disorders, initially it serves a function of allowing the relief to set in, and then over time creates additional consequences in that person's life that they feel that they can't handle. And so turning back to that substance or turning back to the eating disorder as a way of either feeling in control again or wanting to numb out and escape. All right, so what we often see as a response to many of these individuals with co-occurring disorders is that they develop cross addictions. So it is possible that they might jump from different substances or different types of eating disorder behaviors over the course of their disorder over the years. And for many people that I've worked with for decades that they have struggled with these behaviors, they may jump around from extreme restricting, for example, to binging and purging because of that feeling of no longer being able to have the willpower to be over controlled in that way. And so jumping from addiction to addiction, so to speak. In the recent years, as I had mentioned, that we are a research institution, my colleagues and I put together some research that is still unpublished, but I wanted to share some of the findings with you today. And this is, we're hoping to be published in the Eating Disorder Journal and Treatment and Prevention in 2019-2020. What our findings was that there are temperamental traits that make cross addiction much more likely. And the results showed in particular that for individuals with co-occurring eating and substance use disorders, they had a greater number of comorbid psychiatric diagnoses, as we know, and were also more likely to be prescribed mood stabilizers. But what we also found was they had greater difficulty engaging in goal-directed activity. They had higher impulsivity rates. They had more limited access to emotion regulation strategies and higher reward sensitivity. And we additionally found that there were trend level differences suggesting that these individuals were more likely to engage in objective binge episodes, be diagnosed with panic disorder and post-traumatic stress disorder, and to report higher trait anxiety, global emotional dysregulation, and sensitivity to punishment. So what we're seeing is across the board, the individuals who end up developing co-occurring disorders tend to have these general temperamental traits that sort of set them up, so to speak. So going back to that slide that I had about the brain and how nature sort of plays a role in this, in many ways we have seen that in our research that these individuals are sort of set up temperamentally to be more likely to be vulnerable to co-occurring disorders. So I wanted to present a few profile of the types of COD, co-occurring disordered patients that I have worked with. And you can see in these four profiles that each of the individuals are individuals that are very different cases and yet all present some very specific and challenging experiences for the clinician to work with. And so I wanted to sort of highlight what some of these were and how we addressed. So the first is Maureen, and again, all names and identifying information has been changed. But let's say that Maureen is 24-year-old and she's diagnosed with anorexia nervosa. She comes in as extremely low weight and has very rigid thinking, overexercise, and smokes cannabis nightly to manage her anxiety. So at the UCSD eating disorder treatment, we work in a PHP and IOP setting. So this is the example of the type of patient that we would see very regularly, someone who comes in with a diagnosis of anorexia nervosa, who sort of fits the profile of being in a very sick place in their recovery and is needing quite a bit of structure and support, and is using cannabis to manage their anxiety, because as we know, anxiety is the best friend of the eating disorder, and yet the anxiety is continuing to fuel the eating disorder. And so many of our patients have found that cannabis helps them. It manages their anxiety, and in a lot of ways it helps to spark their appetite. And so it might feel like this is the solution. And so how do you treat someone like Maureen in your practice? The second profile is that of Lewis. He is a 33-year-old male with opiate addiction. He has a history of severe trauma, developed bulimia at the age of 16, and his opiate use has increased since losing his job. On first look, this seems like a very challenging case to many clinicians, I would imagine. We don't know how severe his opiate use is, although we know he has a history of severe trauma and bulimia since the age of 16. So we're talking decades of eating disorder behaviors, and his opiate use has increased. So many psychosocial stressors currently in his life. And so imagining that because of the stressors, his addiction is likely triggered and is using more to manage his stress and anxiety around that. Monique is using Adderall and cocaine regularly, and she's doing so to suppress her appetite and to keep her weight down. When she isn't using, she feels sluggish and depressed, and when she is using, she is extremely restrictive in her food intake. Recently, I have seen a wave of these types of patients coming through our program. More and more of our eating disorder patients are finding that stimulants are effective in weight suppression, and you know, I have patients, and I work in an adult program, but we actually admitted a minor into our adult program because her cocaine use was so severe and was really serving to suppress her weight. And within a few weeks of her being in our treatment and stopping the cocaine use, her weight increased quite dramatically, in fact. And at one point we were concerned about refeeding syndrome, but we were monitoring very, very closely. We have a team of excellent dietitians and psychiatrists and registered nurses who were on board monitoring her weight restoration. And you could just see that her weight, she was at an incredibly low weight for someone of, you know, of her, for her needs, for her particular needs. So this was a good example of someone who was using stimulants for that reason. And finally, Tamara entered treatment with a recognized substance use disorder and without a recognized substance use disorder, excuse me. So this is a frequent experience that we have, is someone sort of like falls through the cracks and doesn't endorse substance use, and often doesn't doesn't acknowledge it. And so we think this might be a straightforward eating disorder case, and come to find out that her alcohol meets binge drinking criteria and acknowledges that it tends to exacerbate her purging behaviors. And so this is someone that we might have to go in and reassess or review her notes more carefully and ensure that she is obtaining the exact type of care that she needs to have within our program. So as we know, these patients with co-occurring disorders tend to experience very high risk characteristics, which I think makes this patient population somewhat challenging and scary to work with, and some clinicians fearing having them on their caseload. And it's for very good cause. There are many life-threatening disorders at play here, and increased risk for suicide. We know that both eating disorders and addiction have very high mortality rates and very high completed suicide rates. There are frequent and enduring relapses, oftentimes low self-esteem. And one of the things that we see most common is the co-occurrence of other impulsive or at-risk behaviors. And that can include stealing, shopping addictions, promiscuity, sex addictions, gambling, self-harm, etc. And in fact, in a meta-analysis of 249 individuals with mental illness, individuals with anorexia nervosa and bulimia nervosa had rates of suicide that were higher than any other psychiatric disorder, and 23 times more than seen in the general population. In 2008, a study came out reporting that in all eating disorders, anorexia nervosa binge purge subtype was the most associated with the highest risk for death. And women with alcohol use disorders are 20 times more likely to commit suicide than the general population. As previously mentioned, mood and anxiety disorders often co-occur. We see frequent hospitalizations, medical complications, and early mortality. So some common treatment options, many of which you will be familiar with. I think the most common and often the most widespread for our patients is involvement in 12-step communities such as NAAA, Al-Anon, CODA, and other similar self-help groups such as Smart Recovery. And these communities offer peer support, offer a non-judgmental place to talk about addictions, cravings, triggers, and offer a place for people to feel welcome, comfortable, and at home. And so these are integral to our community as mental health clinicians, that we work alongside these self-help groups to further bolster the support network of our patients. Motivational interviewing and interventions are radically important to this. If you haven't been trained in motivational interviewing, I highly recommend that you do so, and I'll speak more to that in a few slides. Especially in working with this patient population, it is an opportunity to provide a very client-centered approach that focuses on strategies, that change strategies borrowed from traditional therapy, and allows people to explore and resolve their ambivalence about behavioral change, because many of our patients don't have the desire to change or are unwilling to give up their behaviors. And so this is a tool that I think every clinician should have in their tool belt. There are also contingency management options that many existing addiction treatment programs already use, and they are carefully designed and implemented to retain patients in treatment, including to increase therapy attendance, reduce or eliminate drug use, and promote adherence to medication and other therapeutic regimens. So the most researched form of contingency management is a voucher-based contingency management. So an example of this might be if someone is offered a token or a gift card or a monetary incentive every time they test negative for a drug test, or if they are honest about their substance use. And believe it or not, these contingency management techniques do work for people, especially people at the early stages of change when their ambivalence is very high. They sort of need that external reward motivator to kind of keep them on track, to keep them focused, to keep them engaged. Cognitive behavior and dialectical behavior therapy are two evidence-based treatments that we use for the treatment and prevention of co-occurring disorders. Much literature is out there. Many of you may be familiar with these approaches. I will speak a little bit more to them in the next slides. But just know that they are supported by evidence in the literature and are very viable and excellent treatment options for this patient population. And finally, I think it's imperative, and I know not every clinician agrees with me, but I do believe that pharmacological interventions, especially with this population, are radically important to the treatment of co-occurring disorders. They're often used in the withdrawal phase of treatment, for instance, with alcohol withdrawal and opiate use disorders. They also provide relief for post-withdrawal symptoms, help manage cravings, and prevent relapses. I have to say we work with an incredible nurse practitioner who is certified in the field of addiction and uses these medications to help support and manage the concerns and needs of our patients. And we have seen a huge evolution in the last decade or so of the types of treatments available for our patients, including Suboxone and naltrexone, methadone. These are medications that can absolutely give someone a leg up in their recovery. And so I would highly encourage you to consult with or work alongside psychiatrists or a addiction specialized nurse practitioner to provide you with information on that. Let me turn off this light and see if that helps. I hope this is not too dark. All right, so you might be wondering, what are the empirically supported guidelines for integrated care? This is, I think, the main goal of my presentation today, is to offer some information and guidelines on how exactly it is that we can create integrated care programs to meet the needs of this patient population. And I, again, want to put in a plug for Timothy Brewerton's work, Amy Baker-Dennis and Tamara Pryor in their book, Eating Disorders, Addiction and Substance Use Disorders. They give a very thorough outline of how to provide integrated care, and much of which we've adopted in our program and we've found to be incredibly successful. And even if you don't work at a higher level of care like I do, there are aspects of this that I think are very valuable for you. So definitely worth the read. And I added this quote. This was a quote that I had originally put into my article a few years ago on the ED Hope website, that the problem is that many treatment providers focus on addressing the most acute disorder first, and then refer out for the secondary disorder at a different location with a provider that may contradict the treatment approaches of the first. So we know that developing a comprehensive clinical approach to the treatment of co-occurring disorders will absolutely improve treatment delivery, reduce time in treatment, lower overall costs for the patient, improve treatment outcomes, and lessen consumer confusion. It's a mouthful. So here are the guidelines for integrated care. We want to recognize that these services, again, often exist or can potentially be adapted for higher levels of care, and as well as, you know, IOP and or outpatient therapy to some degree. So keep this in mind depending on what the individual practice is that you are involved in. So we want services to be organized in a comprehensive and integrated manner, which includes the following: a multidisciplinary team that has a psychiatrist, therapist, and dietitian at the very least, who are trained in evidence-based treatments for eating disorders and substance use disorders. So what we don't want is for someone to go to a treatment center who might say that they can provide treatment for the concurrent eating and substance use disorder, and then have no staff members who are trained or certified in one or the other. And unfortunately, we do see that in some treatment programs where they say they're co-occurring, and then what that means for them is that they send their patients to one or two outside self-help groups a week. And that's not what we consider to be co-occurring. The members of the team need to be able to address both the eating disorder and substance use disorder, and have been well trained in evidence-based treatments for substance use disorders to be able, and eating disorders, to be able to say that they provide integrative care. The second is an importance in providing comprehensive evidence-based screenings for eating disorders, substance use disorders, importantly, other psychiatric disorders, medical conditions, and relevant lab testing. You cannot have an integrated care model without addressing the whole person, addressing all of the things that might play a role in the progression of their eating and substance use disorder. So types of comorbid diagnoses might include panic, OCD, PTSD, medical management, such as one example of this is what we call diabulimia, diabetes and bulimia. I've had a few patients, and at the time I didn't know a whole lot about diabulimia, so I had to sort of jump into that field. But for those of you that don't know, it's for individuals who have diabetes and use insulin restriction and purging to suppress their weight, which puts them at incredibly high risk for medical complications. And we've had to work very closely with their medical providers to be able to do the treatment here in a way that kept them safe. And so diabulimia was an example of the types of medical conditions that we had to be aware of and be able to work with very closely. And individualized treatment plans, number 3, that integrate both eating disorder and substance use disorder. So there has to be sort of a seamless weaving of treatment plans incorporating eating disorder and substance use treatments. CBT is a cornerstone for this, but DBT is providing an incredible amount of emotion regulation and distress tolerance, learning opportunities and skills. And so we are, our program is based in DBT, and in fact, we've adopted the DBT for substance use disorders model and into our program because we have found it to be the most comprehensive and helpful approach to managing our COD patients. And so if you're not familiar with DBT for SUDS, it's an excellent source of information, also evidence-based, and one of the key components of that is something called dialectical abstinence. In addition, family therapy is an incredibly important and necessary part of treatment, and we know that family involvement increases the success rate of our patients, as does longer periods of treatment. So for people with co-occurring disorders, it's incredibly important, research is backing this up, that they obtain a longer period of treatment than maybe the standard, and at a minimum 3 months of treatment at the PHP level, for instance, is indicated for this patient population. Continuing on with our integrated care model, number 4 of our guidelines is, and this is an important one, services that are provided in the same location by the same providers, if possible, in a stepwise integrated fashion. And so here the focus would be on problem solving, coping strategies, affect regulation, interpersonal relationship strategies, and relapse prevention. These are all essential tools and components of the services that should be provided in the same location. There should also be a management of eating disorder behaviors. In DBT, we use something called a diary card to help track the frequency and intensity of the behaviors. And there should also always be some type of testing or monitoring for drug use. So we do weekly, sometimes up to 3 or 4 times a week, drug screens within our clinic to ensure that we have all of the data that we need with understanding that where the patient is at with their substance use, whether they're being honest with us, etc. We also provide medical monitoring, including regular weigh-ins, lab testing. We supervise all meals and snacks. We have a bathroom supervision and exercise monitoring, which are all necessary and essential components of the integrated care model. And if for some reason these services are unable to be provided in one location, as is often the case with resources or staff knowledge being limited, there should be a plan or contract to manage services elsewhere if needed. So constant collaboration and consultation with the other providers involved in the case. So as you can imagine, there are some unique challenges, some of which I've already mentioned, but certainly want to highlight the whack-a-mole effect, which was included there in my title. So if you've had the experience of working with individuals with co-occurring disorders, you might know that as one set of behaviors improves or decreases, another set might increase. And I think this is what contributes immensely to the patient's frustration and to our frustration as clinicians. We just can't seem to juggle all the different and moving parts. And so we call it the whack-a-mole effect because it feels like you're constantly batting out these different behaviors that keep popping up, these different symptoms that keep popping up. And so it's true that people get tired, they get frustrated, and it feels like it's never going to end. And the good news is that it does. And there's, once the initial behavior stabilization occurs, people have found that their behaviors do trail off and they're able to identify some of the deeper underlying issues that are fueling and maintaining the behaviors. And so whack-a-mole is sort of like an extinction burst. It immerses itself very strongly at the beginning, and then it improves with consistency and structure. And so you'll have less and less of the experience of the whack-a-mole. Another challenge that we see is that there is quite a persistent nature to these disorders, and there's a chronicity that we don't see necessarily in other mental health conditions. And so then the persistent nature and chronicity of the independent disorder in itself can be very challenging to deal with, right? For those of us who work in the eating disorder field, we know that sometimes people struggle with these behaviors for decades, and this is not a fast changing disorder. It takes time, and it takes patience, and it takes a lot of support for someone to really turn around and have lasting recovery. So that presents a unique challenge to working with co-occurring disorders. And also sometimes, as I previously mentioned, their motivation for change is low. And in particular with eating disorders, what I have seen, and I've sort of identified it as egocentric, meaning that within itself, the eating disorder is in harmony with the needs or wants of the individual engaging in it. And sometimes it's consistent with the individual's ideal self-image. So it might be maladaptive, but in many ways, the individual feels very good about having lost a significant amount of weight, or very good about, receiving support and attention from loved ones because they look ill or unhealthy. So in that way, I think eating disorders in particular can be very challenging because they tend to be egocentric for many, many people for a long time. Of course, that changes. But at least from the initial period, I've heard countless patients say, it makes me feel like I'm good at something. It makes me feel like I'm in control, that this is my identity, that this is something that I can do that other people can't do. And finally, there are additional maintaining factors, and particularly, I think, with the higher levels of care, like inpatient or residential and even PHP, is that once these individuals return to the people, places, and things that are, triggers to them in their life, it's very easy to slip back into some of these old feelings, beliefs, and behaviors. In fact, recently there's one patient that I've been working with who we ended up having to send her to a residential treatment for her alcohol use disorder. And it's challenging because many substance programs, didn't want to accept her because of her eating disorder, but we found one that did. And what happened was she did very well. She did incredibly well in the program. She loved the program. There was the structure that she needed. And, she reached her 30 days and obtained a chip and felt really good about that and was very excited, and stepped down and was awaiting, a transition to a PHP program. And in the process of waiting those 2 or 3 days, 4 days perhaps, she ended up slipping and drank. And this was incredibly frustrating for her, and she felt absolutely horrible, and has to sort of pick up the pieces of her relapse and trying to figure out, can I do this? And she said to me the other day, I feel like I might not be strong enough to do this. And so there are, those triggers in people's lives that they're not immune from. They're going to stay vulnerable to those triggers, and that does maintain the behavior in many ways. Something to be aware of as a clinician that is working with them. So you might be wondering, with all of this, these challenges, how can I prevent my own burnout? How can I manage my own emotions and feelings about the situation and continue to be an effective and successful therapist? And I think that this is something that crosses my mind regularly, because I know that if I am not doing well within myself, if I'm feeling tired and frustrated and overworked, then I just can't do my job in the way that my patients need me to do. So here are a couple tips. Of course, there are many, many more. But what I have found to be helpful is internal cross-training. So when I first started the co-occurring disorder track at UCSD, we were a party of 2, myself and a certified addiction specialist that I hired. And it was great that, the 2 of us had the knowledge that we had, but certainly within a program as big as ours, that wasn't enough. And so from 2 back in 2014 to, gosh, I want to say maybe 10 of us at this time, combination of therapists and nurses and psychiatrists who, as I mentioned, specialize in addiction psychiatry. We're now part of a team, and I continue to provide trainings to our bigger eating disorder staff to help in assessing and looking out for substance use behaviors and high risk behaviors. And so cross training has helped take some of the pressure off of me and allowed me and my colleagues to work together to support our patients. But if that's not possible, you might find that collaborating or consulting or receiving a specialized supervision can be really helpful. And so in our clinic, we do a weekly consultation team meeting where we talk about our COD patients in our COD program and provide support to each other. And one of the sort of premises of this consultation team, which is founded in the DBT principles, is that these patients belong to all of us and not just one of us. And so if we are struggling with a high risk case, then all of us are taking the responsibility for that case and ensuring that that case is getting the care that it deserves. Another one that I added to this list might surprise some people, but I do absolutely think that motivational interviewing is not only effective with patients, but I think it also prevents clinician burnout. And what I mean by that is it takes so much of the pressure off of us as clinicians to convince our clients that they need to change. And it allows the client to sort of come to that self-realization. And that pressure off of us, I think, a long way in terms of allowing ourselves to feel like, this is something that, either we make or break this person's recovery. And it's, as much as I know from a logical standpoint, that's not true, but sometimes I feel that way, that I am absolutely responsible for that person's success. And I think that getting back to my motivational interviewing approaches really takes the pressure off of me, and it allows me to have conversation with my ambivalent and pre-contemplative clients that takes the defensiveness off the table, and we're not engaging in any type of defensive or confrontational discussion, which, you know, at the end of the day, we all know how depleting that can be. So motivational interviewing, I think, is an absolute necessity for preventing burnout, as are our own self-care strategies. More and more research is finding that there is a major benefit to mindfulness, and it actually changes the structure of our brain, and it allows us to experience feelings of relief and contentment and balance and focus. And, you know, I'd love to develop my own practice in a greater way, because there are absolutely benefits to mindfulness that we endorse with our patients and sometimes don't utilize ourselves. And finally, one of the necessary components of reducing burnout for me is understanding the butterfly attachment profile. And so I'll share about that in a moment. The butterfly attachment is a concept taken from DBT, where it's sort of this belief that our patients with substance use disorders in particular tend to behave like butterflies, that they fly in and out of the therapist's hand and departing just at the very moment when the therapist believes they have landed for good. And so it's sort of this belief that the clients, it's an understanding, in fact, that the client's primary relationship is often going to be with their substance, and their relationship to us as their clinician is secondary in many ways, especially for the individual who's very addicted or who is very much involved in their behaviors. And so understanding that they're going to have episodic engagement in therapy, they're going to have failure to return our calls or participate in sessions, and ultimately can result in early termination from treatment. So these are patients that will attach just so much and then fly away when the opportunity arises for them to be back in their behaviors. And sometimes we have very little power to persuade them to do the things that they prefer not to do. And the reason why I believe that this is helpful in understanding and reducing our burnout is that if I know this ahead of time, then I can be proactive about making sure that when this does happen, there are things that I can do to engage my client back into treatment and engage them back into our process together, into the recovery process. So I'll talk about that next. So one of the things that I do for these butterfly attachments patients is really work hard at the front part, on the front end of treatment, to build and connect with their support system. So what that means is that I understand the tendency for them to have a butterfly attachment, and that I can be proactive in identifying and engaging with their network of support. And this includes family, friends, partners, neighbors, associates, co-workers, because when the time arises that, you know, when difficulties are presented, I can reach out to these people and say, hey, you know, I haven't heard from so-and-so in the last day or so, and I'm worried. You know, do you know where they are? They didn't attend therapy today. Do you know how I could reach them? Is there a way that you can bring them in to our clinic today? And so often having that connection with the supports, and not just the family, but really to broaden that net as much as I can, I will have a lot more success in re-engaging them back into our work together. And then also building a network of support within my professional alliances, and that is having a team to consult with, to be included in various trainings with, and to consult and discuss, you know, how to support each other and provide feedback on very difficult cases. You know, your coworkers or your colleagues have skill sets that are different from your own, and they can advise you in ways that maybe you didn't think to look at. So I think this is incredibly helpful in managing, you know, burnout and managing butterfly clients. So in one of my final slides, I want to mention that and speak a little bit more about the dialectical abstinence approach that I mentioned earlier. We are a DBT program, and this model is one that we felt not only was backed by the evidence in the literature, but also fit really well with our treatment model and what we were hoping to do. So the dialectical abstinence approach is sort of the synthesis between abstinence and harm reduction. So on the one hand, many patients adhere to swearing off all addictive behaviors and abstinence only. And on the other hand, patients might say, well, I want to deal with harm reduction because I still want to use, but I want to reduce the risks and the consequences of my use. And so the dialectical abstinence approach is basically saying, hey, we're going to commit to abstaining from our primary substance and our most problematic substance. And I make a commitment for a day, a week, a month, whatever the case may be, and I work very, very hard to abstain. I do everything I need to do to abstain from that substance. And in the event that I should have a slip, which as we know often happens, I have a plan, or what is called in DBT, a cope ahead for what I'm going to do to get myself back up and going again. So if I should have a slip and I drink one night, what am I going to do the next day to get back on track with my sobriety? So that is what we call the dialectical abstinence model, and we support the patient in that model. We openly talk about slips that happen and urges and cravings, and what do we do to do the next best thing. So in conclusion, integrated treatment programs are very valuable in understanding the complexity of co-occurring disorders. They address multiple symptomatology and help the individual obtain a fuller and, most importantly, more lasting recovery. We know that a collaborative multidisciplinary team is essential to working with this patient population, and they are the best qualified for providing efficacious treatment. And it takes a community of support, structure, and consistency to help the individuals manage, recover, and ultimately heal from their co-occurring disorders. This takes time, you guys. It's something that happens with time and support, and not just support for the patient, but support for the clinician, that team that I mentioned earlier. And finally, and this is my experience and my hope is it's yours as well, that despite the unique and complex needs, the rewards are worthwhile and the outcomes are actually quite life-changing. Thank you guys so much. I hope we have a minute or two for questions. I apologize for going over. Thank you for allowing me to present my presentation today.
Yeah, thank you so much, Gina. That was really, really in-depth and educational, and I learned a lot, and it was really, really wonderful. Thank you so much.
Thank you.
Yeah, I just want to let everyone know, if you have any questions at this point, feel free to put them in the chat or the Q&A box, and I'll wait for a little while to see if we have any questions that pop through. Actually, Ron asks, what is a PHP?
Oh, thank you, Ron. I'm sorry if I didn't clarify that. So a PHP is a partial hospitalization program. It's a step down often from inpatient or residential treatments, and it offers anywhere from 6 to 10 hours of treatment per day. In our clinic, we offer both options, a 10-hour and a 6-hour treatment, 6 days a week. And at night, the patient goes home and gets to be with their family and friends in their environment. And what's important about this is that they are faced with some of the same environmental cues that they would be in an outpatient or IOP setting, but they have the support and the structure of a high level of treatment. So they get to come back the next day, and we provide very intensive therapy support for them. Like I said, 6 days a week in our case.
Wonderful. Great question, Ron. Thank you. I'll just wait for a second for anyone else to see if they have any other questions while I just give everyone an update on the CE survey. So in the chat for the conference, I posted a corrected link for the CE survey for our first presentation on food and faith. So you'll see that new link right there. And then underneath that, I also posted the CE survey link for Gina's presentation on demystifying whack-a-mole unique considerations for the treatment of co-occurring eating and substance abuse disorders. So you'll find that new CE link just under the one for the first presentation as well. So they're both there. I try to get back to as many emails that I received as possible. So please continue to let me know, but everything should be good, up and working now. So if you are a part of this presentation, please take that survey and we will be able to get you those CE credits. So thank you for your patience with us. Gina, just while we have you here for one more minute before we send everyone else on a break, something that you talked about a support network, and especially between clinicians, and how important that is. For those clinicians who are watching who maybe primarily treat eating disorders and then realize that they need to refer out or bring someone else into the treatment team so that it can be collaborative and it can be integrated, how would you recommend that they go about maybe finding access to some other members, including other members of the treatment team?
Absolutely. Yeah. I'm a strong advocate for networking. And I think clinicians sometimes shy away from networking, either because it feels a little schmoozy or that we're, there to market ourselves. But really, I see the primary goal of networking is getting to know who it is that I can collaborate with and build a community with. And I think that networking allows me to find strengths in other clinicians that, I may not exhibit myself. And so I am very blessed to work a part of a very strong team here at the clinic. But for those of you who are solo practitioners or who just don't have that visibility with other clinicians, I try to identify trainings or networking events that would put you in contact or expose you to people who work in an area that maybe you want to learn more about, or maybe you want to develop relationships with, and go out there and meet them and develop a group of people that maybe even a consultation team that you all have different clinical interests. You come together and you meet maybe once a month or once a week, and you discuss a case that might be a valuable part of the care for your patients. One more thing, I found that it's extremely helpful to have grad students that I've worked, that I was in school with, or that I experienced, colleagues who had been involved in different community agencies in my area that I reconnected with. And so that was another way to collaborate. That was very helpful.
Awesome, wonderful. And we've got another question from Natalia, and she asks, is the addiction to cocaine a behavior that attempts against life, or it attempts against the quality of life of this client?
That's a good question. I'm wondering if Natalia could tell us a little bit more about that question, because I'm wondering if I have the same sort of thought response to her than she's meaning. Is there any more that she can say about that?
Yeah. Hey, Natalia, if you're still there and you want to maybe give us a little more insight into your question, that would be great.